everyone. Welcome to our monthly webinar for the Lifestyle Psychiatry Caucus. I'm Dr. Gia Merlot, and today we have the pleasure of having Dr. David Bowman talk to us. He is a lifestyle medicine physician and pediatrician. He went to Howard University for undergraduate and into Indiana University for medical school. He has done residency at DC Children's and did global health with HIV work, as well as went to Botswana, Nigeria, and Haiti. He currently works at Howard University Hospital, board certified in pediatrics and lifestyle medicine. He has some really interesting, creative ways to discuss health equity in lifestyle medicine with us. He's on the board of trustees was on the board of trustees for American College of Lifestyle Medicine. I don't know if you've rolled out yet, but he has what he calls a lifestyle medicine revolution and other sort of community-based interventions that he has authored. So I'm really excited to hear what he has to say. He is our leader in this space in the lifestyle medicine movement, bar none. So David, please, Dr. Bowman, please, we're really excited to hear what you have to say.
Thank you so much for having me. I'm very excited to be here. Absolutely excited to be here. I'm glad that I've had this opportunity, and thank you, Gia, for all your leadership in all the multiple areas that you are a leader. So I'm very glad for what you are doing in our community. And so today I will be talking about health equity achieved by lifestyle medicine. Gia gave me a good introduction already. No financial relationships to disclose yet. Hopefully they'll come up later, but nothing so far. So we're going to talk about some factors that lead to health disparities, discuss how lifestyle medicine and health equity can and should intersect, and discuss the role of partnerships in offering lifestyle medicine to the underserved. I'm going to start off with a case. I love starting off with cases. To me, I mean, numbers are great, but I think it's really good to have cases. 29-year-old Black female develops blood clots in her lungs and in her legs after having leg surgery and then flying, and she was told going forward she's at risk for blood clots. 7 years later, she's pregnant, delivers a baby by emergency C-section, was having some chest pain. She asked to be put on heparin, but was denied that because they said it's going to make her C-section incision bleed. She was ignored. She asked for a CT scan of her chest. It was ignored again. The patient thought that the pain meds, the nurse thought the pain meds were causing the patient to be confused. The doctor did ultrasounds of the legs and it was negative. She kept advocating for a CT scan and eventually got one and showed a life-threatening pulmonary embolism. She required more surgeries over the next few weeks. And what she said was being heard and appropriately treated was the difference between life and death for me. I know those statistics would be different if the medical establishment listened to every Black woman's experience. And this person, unfortunately, this happens in many cases, but in this case, that was Serena Williams. So if Serena Williams herself has problems advocating for herself, advocating for getting the care that she needs, what about the average Black woman who is in a similar situation? Oh, I'm not sure if you guys are old enough to remember Edwin Moses and Michael Johnson, two of the greatest who have ever done it in track and field. And Michael Johnson ran the 200 and the 400 open, and the Edwin Moses ran the 400-meter hurdles. And so if you go back and think about, they crossed over just a little bit in their careers. Edwin Moses is a little bit older. But if you ask them at the peak of their careers to both run a 400-meter of their respective races, Michael Johnson would win every time. And why is that? Because Edwin Moses ran over hurdles. So he had hurdles he had to overcome in order to achieve what he needed to achieve and to become the best hurdler that probably ever existed. But he needed to overcome that. So the story about this is there are people out there who have so many hurdles that they have to overcome, and we don't take that into consideration. And so it was important for people to know that these hurdles might be genetic susceptibilities. It might be the neighborhoods they grew up in. It may be biased policing and the legal system. It may be policies that promote separation of parents. It may be finances or opportunities or emotional stress. These are hurdles that many people have to overcome, and they might be judged as if they have no hurdles, but they have them, which kind of sets them back or makes it more harder for them. On that note, I'm thinking about epigenetics and health disparities. So, what is epigenetics? It's really that the genes that we're born with can be significantly influenced to either create disease or create wellness. A lot of it is because of the lifestyle choices that we choose or to our environment. So for instance, if you think about this picture, the mother is the first generation, the fetus is second generation, and especially if it's a female baby, a female fetus, the female fetus is going to be born with all the eggs she'll ever have. So if mom is either smoking or she is nutritionally deprived because of either by choice or by her neighborhood or what have you, if mom has a lot of emotional stress or a lot of interpersonal interactions, or she can't sleep because of noise, or she's not, all these things make a difference in the eggs of the third generation. So what I'm dealing with now has something to do with what my grandmother, my maternal grandmother, had to face. So it's like essentially you're adjusting the child's health thermostat. So you can affect the child's health for the positive or for the negative based on what happens in the womb and early on in life as well. Now you can actually change um, the thermostat, so to speak, for that child. Now, in terms of where this comes from, so psychosocial stress really has an impact on our epigenetics. And so it includes hypertension and breast cancer, preterm birth, and DNA methylation that happens for has an impact on epigenetics is really important for this. And African Americans tend to endure more psychosocial stress, excuse me. So because of that, it's not like it's just because of their lifestyle. We can look at them and say, man, if you just eat better, everything would be fine. But we can't just blame their personal life choices. It may be the epigenetics that was passed down to them. It may be epigenetics that happens because of their environment, as well as their personal choices. Think about this health disparity iceberg, and we'll talk about that shortly. But what is, health disparities? So the Healthy People 2030 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and environmental disadvantage. So for African Americans in particular, 60% more likely to be diagnosed with diabetes and twice as likely to die from diabetes, more likely to die from cancer than other groups, more likely to die from heart disease, and more likely to die from hypertension. And it seems like that's just like, man, Black people just got the short end of the stick. But that may not totally be the case. Hispanics also have a lot of health inequities. They are more likely to live in poverty and be uninsured, have more poor health outcomes, have more difficulty finding a doctor, especially with the language barrier sometimes. They often get diagnosed late with breast cancer, and often are less likely to use mental health services than other groups. And there are some initiatives to help to assist with that, such as expanding Medicaid coverage to all who have low incomes, regardless of immigration status, and removing barriers to getting and staying enrolled. Like today, I saw somebody in my clinic. There's a family of, well, mom has 6 kids, but 3 were being seen today, and one couldn't get seen because she didn't have insurance. The insurance lapsed for that one particular child. And it's just like, if we can remove some of these barriers, it's been really helpful. And then we can increase the capacity of the healthcare safety net, especially doing more FQHCs and developing more Latinx health professionals. Those are things that could help. back to this iceberg. So if you think about what's above the iceberg, those are the health conditions that we see that have health disparities associated with them. So the hypertension, the diabetes, the heart disease, the prostate cancer, the breast cancer, and poor maternal infant health, just name a couple, right? And it seems as if the things that are underlying, like the systemic racism, the discrimination, unequal healthcare access, unequal healthcare treatment, bias policing, income inequalities, unhealthy food environment. It seems like these kind of things are directly linked to these things that are above the iceberg. Now, we as in the healthcare field often can't take all of those into account. We do have access, we do have control of access, we do have control of healthcare treatment and making sure that those are equally distributed. But the question is, would increased access be the main answer? So access to care absolutely helps tremendously to slow the progression of disease. However, it might slow the progression of disease, but doesn't reverse disease, right? Standard of care does not address the root causes of the problem, doesn't really address how to reverse the healthcare problem. And there's still this issue of the conscious and unconscious bias among healthcare providers. So going back to 2002, when the Institute of Medicine's landmark report of unequal treatment came out, it really highlighted disparities that were in care amongst racial and ethnic lines. And the question was, how can these disparities exist when health systems and healthcare professionals, they really dedicate themselves and to try to provide the highest quality of care to all patients? How could this happen? How could we end up having health disparities? Some of the findings that they saw were that racial and ethnic disparities in healthcare occur in the context of broader historic and contemporary social and economic inequalities, as well as evidence of persistent racial and ethnic discrimination in many sectors of American life. So it's not just that it's what's happening today. Well, hey, I'm not racist, but just because you may not be racist doesn't mean that the systems are still fair. And then talks about bias, stereotyping, prejudice, and clinical uncertainty on the part of healthcare providers may contribute to racial and ethnic disparities in healthcare too. So it's just, it's that unconscious bias in particular. And then Black patients tend to prefer a Black provider, but if you have unequal amounts of Black providers in healthcare, then that reduces your access to care. What recommendations do they suggest? So standardizing care. So if you have a protocol, the protocol is followed no matter what that patient look like. Educate the healthcare team on unconscious bias. And I'll talk a little bit about unconscious bias in a little bit. Taking steps to improve access to care. You may be using more community health workers, having more multidisciplinary treatment and preventive care teams that are involved. And then really kind of understanding the cultural and linguistic diversity of patients. So for instance, using that as an example, so we got to take culture into account when you're looking at different dietary changes. So if you go and if you told me, I mean, I'm plant-based now, but if you told me back in 2015 or 14, hey, I want you to eat some tofu. Tofu? I ain't no tofu. Quinoa. What's that? What's quinoa? Right? I had no idea what these things existed. And so you're trying to get me to eat those things. I'm not gonna eat them because I don't know what they're talking about. Right. So but they said, curry chickpeas. I'm like, oh, curry. You mean chicken? Oh, curry chickpeas. Oh, okay, I get it. Okay, I like curry. Cool. I can get with that. So how to address these problems. So here we are again with these underlying things that are under the water that seem to be causing these health problems. But maybe instead of being a direct effect, maybe these things are causing oxidative stress. And it's the oxidative stress. So these psychosocial things that are going on are causing a physical stress in our bodies. So oxidative stress, for instance, would lead to hypertension, diabetes, etc. So it's that process. So the psychosocial leads to a biological mechanism, and that biological mechanism leads to the health problems. But hey, pillars of lifestyle medicine of whole food, plant predominant diet, physical activity, stress management, adequate sleep, avoidance of risky substances, positive social connections, that blocks a lot of the immune dysfunction. It blocks the oxidative stress and the chronic inflammation, blocks the gut microbiome dysbiosis, and therefore it can reduce our outcomes of disparities in hypertension, diabetes, heart disease, breast cancer, prostate cancer, and poor maternal infant health. So another case study. 3, 5, and 1-year-old Black children brought by the mother to the health center for well child care. These kids were all over the room. I mean, I'm looking around like how they get on the ceiling. I mean, it was pretty bad. They were arguing, yelling, opening all the drawers, despite repeatedly being told to stop. They stopped for about 3 seconds and then keep going. Their behavior is like this all the time. So I thought maybe it was just because they're in clinic. She goes, no, it's like this every day, all day. Hmm. So, my history, the mother is 30 and she's obese. The grandmother is 54 and is on 22 medications at 54. And mom is on, I think, maybe one medication, but she's on her way. The diet history, standard American diet, very high in fast food and takeout food, processed foods, sugars and meats. And in the clinic setting, she brought some Oreo cookies and I think Doritos to kind of help them calm down, supposedly. Um, so now, speaking of unconscious bias and assumptions that I made about the family, I myself, made some assumptions. So my assumption was that they won't be open to changes. I thought to myself, I mean, they're not going to make any changes, right? I didn't think they had access to healthy food options where they live. I didn't think they could afford them if they could find them. And it seems like this is a generational thing. It's not just that mom herself is the only one who is living unhealthy. It seemed like the grandmother also was this, and it's just like, the whole family eats this way. I'll probably not be able to break through. I didn't really think it would work to talk to them about lifestyle changes, but I tried anyway. I figured a lot of times it's easy to assume something about a family, and instead of actually asking, instead of actually offering an option, I just assumed that they probably wouldn't be able to do it. But I said, you know what? Even if they can't do it, I think it's important that they know what could be helpful. So I asked the mother a couple questions. One is, what is the predictable and almost certain future for her health if she makes no changes to her lifestyle? So again, what is the predictable, almost certain future, mom, of your health if you make no changes? And she was like, oh, that doesn't look good. I'm not, it look like my mom. That's exactly. So you might turn into your mom, but not at 54, but maybe at 44. But hey, if you're cool with that, there's no need to change because you're right on track. Then I asked another thought-provoking question that, I'm careful to make sure people understand that because we had shared ethnicity, I had no problem asking this question. But and I've known her for a couple years. But it's still a question that was very thought-provoking. I said, Mom, what is the predictable and almost certain future for poorly behaving Black kids in America? And she was like, and she just had not thought about it. She's thinking about just today. Today, if I can just at this very moment, right now, at this very moment, if I give them Oreo cookies, they'll calm down. They'll be happy and they'll be in a better mood. If I give them the Doritos right now, they'll be happy. She wasn't thinking long term. My gosh, if this stays up, whoa, that doesn't look good for Black kids in America. And so I said, let's do everything we can to try and prevent that by giving their brains the foods that it needs for them to be the best. Mom changed the whole diet for the family. She changed her pasta over to whole wheat from white. They started doing avocados. They started doing more organic foods, doing kale salads and spinach as well. The kids weren't even asking for fast food after a while. They're doing an air fryer with organic potatoes. They actually didn't. They took their nuggets. They still were doing meat, but they mom bought the nuggets herself from the grocery store in the freezer food department and just air fried it, as opposed to going to a takeout place and getting it. So in 3 months, mom lost 15 pounds. So she's on the right path. The kids' behavior markedly improved. They were sitting there still the entire examination. I mean, they were doing that at home. They were stopped fighting, much better behaved. I mean, I was like, oh my God, it worked. I didn't really think it was going to work, but my gosh, it worked. And so I was like, wow, this really shows that one, I started to make these initial assumptions, but maybe I shouldn't, because it might only be one family out of 10. It might be one family out of 20. It might be one family out of five. But that for that one family, it's going to make all the difference that they make a difference. Study three, 16-year-old Black female comes in for health maintenance visits, accompanied by her with her 8-month-old son and her social worker. And the medical student took a took a history and came back and said, she smokes marijuana every day. All right then I made a lot of assumptions. My unconscious bias became very conscious for me. I started having all kinds of, oh, well, I know what she's like. I had all kinds of, I know this is how this is going to go. And I literally did not look forward to having to work with them. I thought, can they go see somebody else? I don't want to see this patient. I literally thought that. Like, I just don't, this is going to just drain me, is what I thought. And so the initial assumptions and bias that might be made in this case, well, I made a lot of them, right? Um, so I decided while the medical student was in the room, so let me go and talk to the social worker. And I was like, what? So most people come with their parents. So you know, why aren't they with the parent? And she said, oh, well, the caregivers or the aunt and uncle were working. And so the social worker came instead. I'm like, well, aunt and uncle, well, why not her parent? Right. So come to find out that her mom had been imprisoned. The 16-year-old's mom had been in prison, and then found out that her mom died in prison 3 days before the baby was born. So, died 8 months ago. And I'm like, oh my gosh. Oh my gosh. So at that point in time, I literally thought, like, you're only smoking marijuana? Like, you need to escape, like really escape reality right now. But I was like, okay, now I get why this person's so stressed. Um, and so I decided, okay, what else can I do? So, like, in addition to her needing counseling, like, let's think about other ways you might relieve stress. And so I literally said to her, I was examining her and I got this idea. I was like, you know what? With all the stress you're dealing with, like, I can imagine, man, with your story, you could be a huge social media influencer, and you could be like, I have all this stress and I'm working it out. I'm actually using physical activity. I'm exercising. I'm a fitness instructor now, and I'm relieving my stress through physical activity. And oh my gosh, I'm eating this way, and because I'm eating this way, I'm dealing with the physical effects, the biological effects of my psychosocial stress. So I don't have the health outcome negative, the negative health outcomes. And so I said, I told her that. I shared it with her. I said, I could see you being like a social media influencer, by changing your lifestyle. Oh my God, I can see it too. I can see it too. I was like, oh my gosh, to go in from, I don't want to see this person because she's going to drain me, to really being inspired, to giving her a future and a hope to look forward to. And to see that was just amazing. So, trauma-informed care, I probably don't have to tell anybody in this group about this, but it shifts the focus from what's wrong with you to what happened to you. And I'm sure it's probably something that you guys are all very well aware of. But it's really when I started doing that, I started saying, gosh, instead of saying, God, why is she smoking marijuana every day? No, hold on, no. Let me see what's going on. Oh, now I understand why you're so stressed. I get why you're stressed. It makes sense that you need to relieve stress every day. You have a lot of stress. Okay, what constructive areas could we see that we might want to do this with? But I could understand at least because I asked that question, like instead of just what's wrong with her, but like what happened to her. With adverse childhood experiences, we really need to think about like how can we do reduce the blame and shame. Like this girl has nothing. Like her mom was in prison. Her mom died. Like there's no need for her to um, feel a certain way about her life experiences at that point. She it's not her fault. And so it's important for us to really try to reduce blame and shame because if you think about it, like this girl in particular, she was exhibiting a normal physiological, biological, and behavioral reaction to an abnormal traumatic situation. It made sense to do it that way. So maybe if these people didn't have their traumatic experiences, maybe they wouldn't have the health problems or the behavioral problems that they do. Case study 4, 5-year-old African-American male, frequent ER visits for asthma. This is the first visit with this provider. It's on inhaled steroids and frequent albuterol use. The typical plan with this, the worsening ER visits is to increase inhaled steroid dose and do oral steroids, etc. Now they saw an allergist. And they found out the person's allergic to eggs, peanuts, tree nuts, and roaches. So it took a 24-hour diet history, which is, I think, is very important. If we can do that, just tell me what you ate yesterday for breakfast, lunch, dinner, snacks, and drinks. You learned a lot just by learning what they did yesterday, 24-hour diet history. So for this patient, for breakfast, they had pancake, hash browns, and kielbasa sausage. Lunch, they had steakums and rice. And for dinner, they said McDonald's. Okay, well, what did you get at McDonald's? Because there's different options at McDonald's. They got nuggets, fries, a hamburger, and apple juice. The snacks were cookies, vanilla wafers, and chips. And the drinks were high C orange, brisk tea, and Kool-Aid jammer. Whoa. So looking at this diet, you clearly could see that this is a highly inflammatory diet. Asthma is an inflammatory disease, right? So, but notice pancakes and vanilla wafers have eggs, but he's allergic to it. So no wonder this guy's having a lot of allergy symptoms because he's allergic to some of the stuff. And so it's triggering the asthma that he's having. And so, like I said, an inflammatory diet could lead to inflammatory disease. So fruits and vegetables, if you have quite a few fruits and vegetables, it can reduce your asthma symptoms by half, which means less time out of school for the child and less time off work for the mother. So my daughter was looking at going to different schools. We are going to change her school. And so we went on a middle school tour. And I just happened to go to one school and I saw their cafeteria slash, eating area. And they had some vending machines. And here are their vending machines. And this is what they are trying to feed our kids. And it's like, why would you do this if you want the kids to be behaved in school? Like if you want the kids to sit there quietly and be behaved in school, you wouldn't be feeding these kids this stuff. And it's so funny because that hello goodness at the bottom, it's like instead of that being hello goodness, it's more like, oh my goodness. Like, oh my goodness. Like these kids are going to be bouncing off the walls and can't necessarily help if you are eating foods like have tons of chemicals, that have tons of, you know, what do you call those? Food colorings, tons of sugar, tons of caffeine. And naturally the kids are going to have more hyperactivity and behavior problems. That's just how it's going to be. So one of the problems is that health equity programs often do not take lifestyle medicine principles into account. So it's great to eat people, but that food may worsen the long-term health outcomes. So you might promote chronic disease, you may be exacerbating mental health problems by the foods that we're giving them. However, on the other hand, many lifestyle medicine programs often don't take health equity into account. So the fee for service payment models go for quantity over quality. and try to get people in and out. It's hard to counsel people about lifestyle changes if you can't get them in and out. So that fee for service model is very difficult um, to promote health equity. And then also, we may have inadequate recommendations for people socioeconomically or culturally. So, hey, just go out in your neighborhood for a walk. Well, my neighborhood's unsafe, so I might not be able to do that. My park is full of people who are, fighting and dealing drugs. Okay, that might not be a good place for you to go to the park. Um, and if you give food recommendations that are not a part of a person's culture, that they're less likely to take on those changes you recommended. And the cost of programs might be prohibitive. A lot of times, I know a number of people who are doing direct primary care, which is a totally great way to go in terms of providing some lifestyle medicine. However, the people who can't afford it are oftentimes some people who need it the most, and they can't afford it. Some of the challenges for health equity and lifestyle medicine is that the impact of systemic racism on options for healthy food and access to providers exists, and so it's hard for people to make a healthier lifestyle. And then there's the culture of food. Our habits, man, and our emotions have a strong pull towards certain foods. And I want to, be clear that there's nothing wrong necessarily with any food choices. I'm plant-based. I strongly recommend people to do, whole food plant-based as much as possible, or at least do as many whole plant foods as they can, right? There's nothing wrong with any one particular food. However, we are not free. We're free to choose, but we're not free from the consequences of those choices. So it's important that people understand you can eat what you want to eat, but just understand that the outcomes that may happen from eating this particular food might you can't escape those outcomes. And there's a lot of cynicism on the part of the healthcare system and on patients. So some patients are cynical, but a lot of times it's us. Like we don't counsel people because we think, like I said earlier, I counsel somebody anyway. Despite my cynicism, I still went ahead and counseled them, but I still had the cynicism. But if we have cynicism and we think people won't do it, we might say, I'm gonna save my time. I'm gonna save my breath. They're not gonna say anything. They're not gonna do anything. And then of course there's the Western medical approach, which is really treating the effect and not treating the underlying cause. Then of course there's always the cost issue. It's always, always, always that cost issue. If you think about it, when we think about the cost of healthy food, we assume, and there's always this assumption that's out there, that healthy food has to be more expensive. But you think about it, whole grains cost the same as refined grains. So if you go out and get some whole wheat spaghetti versus the white spaghetti, they cost the same. But you're getting more nutritional bang for your buck with the whole grains. So even though you're not paying more, you're getting more with the whole grains versus the refined grains. If you think about it, I always say this to patients who say, "Oh, it's so expensive." I said, "What part of the meal costs the most?" They're like, "Oh, yeah, well, the protein or the meat." All right, well, do we have to have protein from an animal source? Like your chicken did not eat beef for its protein, and your cow did not eat seafood to get its protein. Where they get their protein from, they got it from plants, and so can we, right? So beef costs more than beans, and chicken costs more than chickpeas, and lamb costs more than lentils, and fish costs more than falafel. So if they say it costs a lot, like, oh, you know what? If you just cut out the cost of the meat and still got protein with it, you'd actually save money, a lot of money. And with that extra money, then might be able to buy more vegetables, for instance. And then you want to buy things that are locally, if possible, buy them in season. So I know if I get some, what's it called? Some cherries. So getting cherries in season, I might get them for $2.99 a pound, maybe $3.99 a pound. Out of season, they're $9.99 a pound. Dr. Bowman does not buy cherries out of season. And then, I buy apples in the bags as opposed to buying it individually. So that saves a lot of money. So at least probably half your cost is saved by buying the bagged apples and bagged oranges as to buying them individually. The dollar stores. So I did a dollar store tour, and you might want to try to do this yourself. I did a dollar store tour, and I saw that they're nuts. And there's healthy popcorn options like the Skinny Pop and the Boom Chicka Pop. So they're healthy options that are at the Dollar Tree. So you can get that instead of getting chips. Or you can get water instead of soda, and then you can also do beans instead of other, ravioli or something, right? So that you can still go to the dollar store and get foods that can still feed your family without having to break the bank. And if you think wellness is expensive, try illness. Illness becomes very expensive, both in terms of the actual costs of illness, so the actual medical care you may need to do, but other things. So people who may be hourly are now not going to work because they're sicker. You may have to take time off of work to take care of your kids who are not well, or your grandparent or your parent who's not well because of their focus, not their lack of focus on wellness. Vegan entree costs. Here's my issue: is that vegan entrees often cost the same, but they don't give the same sense of fullness. So I know I went at my hospital. They had, so I was so excited. They had some cauliflower steak. I was like, yes, cauliflower steak. That's great. But it's just the cauliflower. That was it. And I was thinking to myself, wait a minute. I mean, the protein source. I'm going to be hungry in 2 hours eating some cauliflower steak. Cauliflower steak is not steak. You're going to have, your satiety comes from fiber, fat, and protein, and there might be some fiber in there, but there's no protein and there's no fat in there. So no, I'm not going to be satisfied with that cauliflower steak. So if they put that cauliflower steak on top of a bed of lentils, then all of a sudden now it makes sense. Actually, I went to what's a place called Hell's Kitchen, and my daughter loves Hell's Kitchen on TV, and so we went to Kitchen to celebrate something for her, and we went there, and it's so funny. I opened up the menu, and I only saw. I guess I didn't. I thought it was a whole menu, and I was like, "Oh, $32? Oh, we can do this. It's not a problem." I didn't open up the whole menu, and I saw the beef Wellington was $74 and the sirloin was $95. I'm like, "Oh my gosh! Hey, you guys, I'm so sorry. I apologize. Um, I didn't recognize the price was going to be like this." But the beluga lentils, they had a beluga lentils option. The beluga lentils were $16 as an entree. I was like, oh, thank God I'm plant-based. Hallelujah. But that makes sense. Like if you are thinking how much did it cost to source these lentils versus how much did it cost to source that ribeye, of course it costs a whole lot less for the lentils, so it should cost less at the end. And so I was very glad to save a whole lot of money on that outing. Um, so now, if the entrees cost the same, but you get less with it, it discourages people from eating more wholesome food because you're not getting as much fullness from your food. And so because the ingredients in plant-based entrees cost less than the animal-based ones, the entrees should cost less than the animal-based ones. And so if you say, wow, gosh, if the usual meal costs $10 and I can, for $7, I can get this vegan meal. Well, I mean, over time, I'm saving, 30% of my money. That's great. So it's important to try as one way to make things cost less is to have the vegan entrees cost less. But maybe we should stop asking why real food is so expensive and start asking why processed food is so cheap. So now, as it relates to nutrition and food insecurity, there are some experiences of people who experience people who have these issues. So there's a couple steps to that. So at first, you might have food anxiety. There's a preoccupation with not having enough food, and so people are concerned: is the food going to last? Is it going to last enough? And then you get to a monotony of the diet. So you decrease the nutrition quality, you decrease the variety, and really desirability. So if you know that these kids are going to eat the nuggets and fries, and you don't want to waste your money, I mean, I'll give them nuggets and fries, right? I know they're happy with it. I know they're going to eat it. But if I said, let me try something different, for this kid, and I'll do some beans and rice and or some a vegan jambalaya, and they don't eat it, then you've wasted your money, your kids are unhappy, and now you're kind of stuck, right? So that happens when people have food and nutrition insecurity. And then after that, the adult intake decreases, and then the child intake decreases. And then eventually you might find that adults will acquire food in socially unacceptable ways. And keep in mind that food insecurity is definitely a source of toxic stress. That's very much a reality for some people. Let's bust some myths and address some barriers. So people will say, these foods you're talking about, it's not part of my culture. But the standard American diet definitely promotes quick and highly palatable food that's really stripped of essential nutrients and has many processing chemicals added. And so you get that the standard American diet is what you're used to. However, your ancestors did not eat like this. So if it's really part of your culture, if you go back 3 generations, 4 generations, you might find that people in rural areas or people who lived in other countries, they ate a lot of whole plant foods. And so that's truly your culture. Your culture has been stripped by coming to America. If you think about it, standard Asian, Native American, Central, South American, Caribbean, and African diets are highly plant-centered, with minimal or fewer processed carbs and meats. Very much a whole food diet, if not a whole food plant-based diet or plant-centered diet. There's old ways. If you guys are not familiar with old ways, they have different diet pyramids for different cultures. And so you can always lead people to old ways to show them ways in which they can eat that are consistent with their actual heritage. Another myth is that they don't sell good food in my neighborhood. Now, unfortunately, this is a real problem and it is systemic and it is purposeful. It is on purpose. People want them to eat. They don't allow you to have certain grocery stores in certain neighborhoods. They discourage that from happening. So, what are some ways you can address that? One, as you buy in bulk, you don't have to go far very often. You might try to freeze some stuff that's amenable to freezing. There's Instacart and Grubhub if you want to get food from places that are further out. Now, one documentary that I watched that is an amazing documentary. I highly recommend if you want to address health disparities, this documentary is fantastic. It's called They're Trying to Kill Us. And it came out maybe 3 years ago or so. It is phenomenal. It's on YouTube and it's on Tubi. And here's a QR code for it. I watched it once, and when I watched it, I was like, "Oh my gosh, I need to show this to everybody." And currently, on my nutrition lecture for my medical students, we watched this documentary together. I recognized the medical students were not going to watch it on their own. I kept trying to like a couple of groups of medical students, I'm like, "Yo, please watch this documentary. Please watch this documentary," and nobody did it. So you know what? I'm going to make you watch it. So, the last group that saw it was like, and the discussion that we had after, um, this medical student said, Dr. Bowman, you really helped me to get back to why I went to medical school. I want to be a healer and I want to address, health disparities. I really want to help the less fortunate and the underserved. And this really helped me to kind of get there. So it is a great, great, great documentary. Other solutions might be to work with community resources. So again, like I talked about at the beginning, if we get the health equity programs that are into health equity to understand more about lifestyle medicine and to partner with them, it may help a lot to work with food banks and farmers markets, community gardens, churches and other community centers and other places of worship, food shelters, produce prescription programs, mobile vans, and FQHCs. And then culinary medicine is a great solution as well to help people learn culturally appropriate food, not just recommendations, but like to see how to cook it. Many people nowadays don't even know how to cook. And so having these culinary medicine programs may help people to find things that are culturally relevant that they may want to cook as well. So these partnering is everything. Partnering is everything. So for the American College of Lifestyle Medicine, there's an initiative called the Health Equity Achieved Through Lifestyle Medicine, or HEAL, HEAL. Um, One of the action steps we had from a health disparity summit solution back in 2020, one of the recommendations was to educate more clinicians on lifestyle medicine and also promote minority clinician representation. Really, really important to do that. Lies in kitchens and culinary medicine to help people to self-advocate, because a lot of times it might be 10 years, 20 years before the medical system catches up. That may be too long, right? We got to do it, help the patients to self-advocate for those who can. There needs to be, we need to advocate for subsidy shifts. A lot of times the food, if you take a Big Mac and take away all the subsidies, that Big Mac might cost $11, not $4. So that's important to understand. If we can shift the subsidies to people to healthier foods, then maybe we might be able to help with health disparities. Building community engagement, like I mentioned earlier, have a lot of cross collaboration programs. There's HEAL has a collaboration with a church where it's a faith and health initiative where to help the church to empower them and to help them with people they serve. And so it's a program that it will eventually become a turnkey program for other churches. Now, the intersection of health and faith for many African Americans, spirituality is very important, where the church can be a source of spiritual and emotional healing, and a place where physical health can flourish or it can be hindered. So a lot of church dinners serve the gospel bird, which is chicken. They often will serve the same foods that the person died from at the repast. On the good side, the Seventh-day Adventists in California use their faith to improve their health, and they are the only blue zone, or a place that people live to the longest to 100. They're the only blue zone in the United States. And so, but they use their faith to help their health. And there are a lot of scriptures that can be applied to help that can help people. So my own personal testimony, in my 30s and 40s, I gained a lot of weight. I had a lot of problems. Constipation so bad that led to surgery. I had an anal fissure that led to an anal fistula. I had reflux, indigestion. My allergies were terrible. My asthma was bad. Eczema was bad. I ended up doing a Daniel fast for spiritual purposes, not because of my health, but because I was trying to figure out, like, my career was changing. I was doing global health and HIV work, and praise God, I got put out of a job because when pregnant women take their HIV medications, they don't pass it to the babies, and so I didn't have any more work to do, which is fantastic. So I did a Daniel fast, like just like Lord, show me what I need to do for my life, right? Um, Not only to have weight loss and rapid relief of symptoms, I felt so good so fast. And I recognize that there's a scripture that says that we are fearfully and wonderfully made. That I am fearfully and wonderfully made, but however, my lifestyle promoted disease. And this is my before and after. I lost 6 inches of my waist. I just felt so much better. So it took for me spiritual strength for me to achieve and sustain lifestyle changes. And in doing so, it changed the health trajectory of my family and helping to break generational health problems. For some people, spirituality might be the resource they need to overcome that challenge of trying to change their health. My program, my wife and I program, it's called Lifestyle Med Revolution. We've had hundreds of people who come through our program to do these Daniel fasts or really kickstarts into a healthy lifestyle that led to permanent changes in their pantry, that led to kids eating differently. And they're learning to train up a child in the way that they should go in terms of the way they eat. My great grandfather is shown on the left. He was a slave who escaped slavery and fought in a civil war for his freedom. And because of his bravery during a battle in South Carolina, he actually did something that got him a Medal of Honor. Or sorry, that got other people medals of honor. And essentially, my dad did a lot of research to get my great grandfather a Medal of Honor for his bravery in Clinton's last week of presidency. And that's his own daughter is there. She was 92 at the time. And so I look at my family right now, and because of what my great grandfather did and what my father has done, it makes a big difference for my life as well. And I think so much about, what all these problems are dealing with. And I am a a example, not example. I am an offshoot of my parents. And think about it, my parents grew up in segregation, and my grandparents grew up in Jim Crow, and my great grandparents grew up in slavery. The the epigenetics that we're dealing with are affect me. However, because I'm choosing, despite those health the epigenetics that were probably lean towards me getting sicker, the choices that I've made can help my daughter to not have to deal with some of those health effects that I may have inherited epigenetically. So, so the goal is to break to generational cycles of negativity that may come down from above, from your parents and grandparents. So take home tools. Many health disparities exist not solely from lifestyle choices, but also from systemic discrimination, policies, and social influences of health. I don't want to call it social determinants of health, but social influencers of health, as well as conscious and unconscious bias in providers. And it's really imperative that those who do health equity work should do so with lifestyle principles in mind. And those who do lifestyle medicine should do so with health equity in mind. And it's really important to build partnerships with community organizations, churches, etc. Um, Doing that provides synergy and improves access to the underserved populations. And it's really important to understand underserved not equal undeserved. The underserved fully deserve lifestyle medicine. They deserve all kinds of access that they need. In fact, they're the ones who often need it the most. So the question I'm going to leave you guys with is, what opportunities do you see for increasing and applying health equity and combining health equity and lifestyle medicine? I want to leave you with that for you to think about. Is what opportunities do you guys see for that? So thank you for your time. Again, I'm Dr. David Bowman, and taking time for any questions at this point. This is my QR code for my website.
All right. Thank you so much, David. Oh my goodness, what a wonderful, wonderful. And thank you for sharing your own story because that actually brings it home in such a way.